Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this dermatology series. Today's episode is all about Lichen Planus, a chronic inflammatory condition that can affect the skin, nails, or mucous membranes. We'll break down the essentials, keeping it simple and practical for your clinical toolkit. Let's jump right in. First, some basic pathophysiology. Lichen planus is thought to be an immune-mediated condition. Although the exact trigger is unknown, associations with hepatitis C and certain medications have been noted. The inflammatory response leads to the classic violaceous, flat-topped papules and plaques. Now, who does lichen planus affect? This condition most commonly occurs in adults between 30 and 60 years of age. The risk factors, as we already alluded to, are certain medications such as NSAIDs or antihypertensives, and in some cases, hepatitis C virus infection. The clinical presentation of lichen planus can manifest in several ways. You'll want to remember the 4 P's of lichen planus: purple, pruritic, polygonal, and papular. And I actually like to add on a 5th P for planar, due to being flat-topped. The classic cutaneous lichen planus is characterized by pruritic, flat-topped, violaceous papules, often with fine white lines on their surface called Wickham striae. So you can see where those 5 P's came from. These lesions are commonly found on the wrists, shins, and lumbar region. Now, other variants of lichen planus include oral lichen planus, which can consist solely of lace-like Wickham striae, or papular, atrophic, or erosive lesions. There's also genital lichen planus, which presents with papules to the glans penis or vulva. Nail lichen planus, which can present with nail thinning, ridging, or fissuring, and can lead to permanent nail dystrophy. And also lichen planopilaris, which affects the scalp and can progress to scarring alopecia if left untreated. It's also worth noting the Keebner phenomenon, which commonly can occur with lichen planus. This is where lesions can occur at sites of trauma. The diagnosis is typically clinical, based on the appearance of the lesions. In cases where the diagnosis is uncertain, a punch biopsy can confirm the diagnosis by revealing characteristic histologic findings. Now, as far as management, this depends on the severity and location of lesions. Topical corticosteroids are commonly used as first-line treatment for localized cutaneous lichen planus. For patients with generalized disease, in whom monotherapy with topical corticosteroids is less practical, topical corticosteroids are often used as an adjunct to systemic therapy or phototherapy. And don't forget patient education. Explain that lichen planus is a chronic condition with potential flare-ups. From a preventative standpoint, avoiding triggers such as certain medications or managing underlying conditions like hepatitis C can help reduce risk. You also want to encourage patients to avoid scratching, as trauma can worsen lesions through the Keebner phenomenon. Now, before wrapping up, here are a few clinical pearls. Number 1. Wickham striae are pathognomonic for lichen planus. Always check for these under good lighting. Number 2. Think of lichen planus in patients with persistent pruritic papules and a history of hepatitis C. And number 3, nail and scalp involvement can lead to permanent damage. Make sure you refer these cases early for specialty care. All right, let's practice some questions. Question 1. A 45-year-old woman presents with an itchy rash to her wrists and ankles, which has been present for 3 months. She denies systemic symptoms. Physical exam reveals flat-topped, violaceous papules with Wickham striae. Which of the following is the next best step in management? Is it A, oral corticosteroids, B, topical corticosteroids, C, antihistamines only, or D, referral for skin biopsy? I'll give you a couple of seconds. If you chose B, topical corticosteroids, you are correct. Topical corticosteroids are first-line therapy for localized cutaneous lichen planus. Biopsy is only necessary if the diagnosis is uncertain. Question 2. A 55-year-old man presents with painful sores inside his mouth that are making eating difficult. He has a history of hepatitis C. Exam reveals white, lacy erosions to the buccal mucosa. Which of the following is the most likely diagnosis? Is it A, oral lichen planus, B, pemphigus vulgaris, C, leukoplakia, or D, candidiasis? If you chose A, oral lichen planus, you are correct. The lacy white patches described are classic for oral lichen planus, particularly in a patient with hepatitis C. Pemphigus vulgaris typically presents with widespread erosions and a positive Nikolsky sign. And candidiasis involves white plaques that scrape off. Great job! Thank you for tuning in to today's episode of the Pro PA podcast. Lichen planus may not be as common, but it's crucial to recognize its characteristic features to guide effective management. Don't forget to subscribe and turn on notifications so you don't miss our upcoming episodes. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you next time.